Okay, let's get started. Welcome to the Healthcare Breakout. I'm Gary Van Kennen, and I'm co-hosting with Judith Van Kennen. Our panelists and subject matter experts are Mark Haney and Alex Tindo-Weisenbanger. So welcome, and let's get started. Judy, would you like to begin? Unmute.
Okay, now you can hear me. Our theological and anti-racist rationale for this work are based on being people of faith. We feel it's a moral duty to ensure that everyone has the chance to live a life that brings health and wholeness to them. Making healthcare accessible and affordable is, we feel, a human right. And certainly scriptures have spoken volumes about caring for those who are the least, the most vulnerable among us, especially those who are marginalized and very vulnerable, such as the stranger, which would be the immigrant, orphans, widows, those who can't afford healthcare today. We also recognize that healthcare is not equal for everyone in our country. People of color certainly are directly affected by that. And we know that there's a growing body of research that shows that centuries of racism in this country has had a profound and negative impact on folks of color, and they're at greater risk for poor health outcomes. So we ask our legislation to consider those things as they look at these upcoming acts presented to them. The principles that underlie our work here are, we feel it's not fair that people with insurance have to pay higher health insurance premiums in order to help cover those who are uninsured. Secondly, human care is a human right. Everyone deserves the same quality of health care, regardless of their ability to pay. And we know that in the United States, we pay 50% more for health costs, and we have poorer health outcomes, and not everyone is covered. We also spend an excessive amount of healthcare dollars on administrative overhead, which would be dramatically reduced if we went to a single payer system. High premiums, deductibles, and co-pays take a significant chunk out of household income. They also lead to medical bankruptcy, and there's less money available for other household expenses. So having said that, we'll move into our requests, and I think we'll take them one at a time, and Mark and Alex will have you speak to those. The first one is the New York Health Act, which is sponsored by Assemblyman Richard Gottfried and Senator Gustavo Rivera. This will provide a public single payer system that covers every New Yorker. So I'm assuming it's Mark would go first.
Yeah, I can take this first. And I assume throughout your day, well, first of all, let me introduce myself. I'm Mark Haney. I'm director of Metro New York Healthcare for All, which is a coalition of community groups and labor unions in the New York City region that work together on healthcare issues, and our core mission is universal healthcare. Just by way of background, I'm a preacher's kid. My dad was a preacher in the Western New York region, so I have lots of familiarity growing up and so forth around communities and people of faith. So I'm really glad to be kind of touching back to that. The New York Health Act is a very comprehensive piece of legislation that would create a universal healthcare program for us here in New York. All New York residents would be covered, no questions asked. It's modeled on the Medicare program, the existing Medicare program, that's upgraded in ways that Medicare actually needs to be upgraded to, some of which has been in discussion in the context in Congress lately around the Build Back Better Act. but that's a conversation for another day. So anyway, this would create a universal program for New York. It's not likely to be dealt with in the first half of this legislative session when the budget is being hammered out, because it's not a budget issue for this year. It will sort of move to the floor legislatively in the second half of the session in April and May, and will be taken up then. That, of course, means that we don't sit on our hands and do nothing. We do have to lay groundwork for when that issue becomes more salient for legislators. And so we are, in our business that we're making around budget issues, we are mentioning we're also supportive of this act, and we'll be coming back to kind of talk with you later more about that in depth. So I guess in the interest of time, I presume we'll have some time for questions and answers. I can get more into the depths of that bill at that point. I think what's probably most immediate is, of course, what's going to be on the table in the budget process, which is now fully underway. The legislative hearings around various aspects of the budget wrap up today. The healthcare one was about a little over a week ago. So the stuff that's in play in there, I can talk about. I'll turn it back to you, and because I'm not sure what your rolling agenda is here.
Well,
what about the Medical Debt Protection Act?
Okay, that I can talk about here. Okay, I'll talk about that and then turn things back. So this is a piece of legislation that will protect consumers from medical debt actions by healthcare providers, particularly hospitals. That these are bills that, quite frankly, they can't pay and they won't be able to pay. And oftentimes what happens in these circumstances is that the hospital sues the patient. Well, first it goes to collections and then maybe a lawsuit. And there are steps being made to foreclose that process of lawsuits altogether, because we don't feel it's appropriate in the field of healthcare, particularly since all hospitals in New York are required under law to be charity, nonprofit organizations and charities. So at any rate, for this Medical Debt Protection Act, for those situations where patients do get sued and there are judgments made, that it would prohibit hospitals from placing liens on their primary residences and garnishing their wages. So at least that provides some basic protections here. The Patient Medical Debt Protection Act is a package of a number of bills that's been floating around for a few years now in the legislature. Each year they chip away and get one or two through. So this is one of the ones for this year. It's not particularly a budget bill, although the budget-related bill, although the legislature seems to be moving this package along alongside simultaneous with whatever they're doing around the budget per se. So it may come to a head sooner rather than later, but if not, it will then become much more of a live issue after April 1st, just like I was saying with the New York Health Act. So I think I'll pause there and send it back.
Thank you, Mark. We'll circle back for questions after a while.
Okay.
The next ask on our agenda is the HEAL Act, and Alex is the high-level expert on that.
Yeah, thanks so much. Again, I'm Alex Tyndall Wiesendanger. I'm the campaign coordinator for the SEIU 32BJ Health Fund, running the Coalition for Affordable Hospitals. So, what Mark just said is actually a great segue into this. Can you imagine a nonprofit organization that sits on billions of dollars of endowment, has venture capital firms, and is a for-profit real estate developer, also putting liens on working New Yorkers' houses to extract money? I am describing the hospital systems of New York, and it is insane. The 32BJ Health Fund, for a little background, is a fund that covers 200,000 lives in New York State. Working people, the SEIU 32BJ is building service workers. So the people and their families who are covered are janitors, doormen, porters, commercial cleaners, security guards. Our folks tend to start at about $18 an hour. And so maintaining affordable healthcare is at the real center of their ability to survive and live in New York City, right? I don't need to tell anyone here how expensive it is to live in this city. And because we're a self-insured fund, which means that we pay every dollar of every claim and are able to understand the details of what's so expensive about healthcare in a way I didn't before I came here. And the most simple answer is the private hospitals' prices. Private hospitals charge working New Yorkers, this is true of our fund, this is true of city workers, this is true of you, you're paying for it whether you know it or not, 3 or 4 times what Medicare charges for the exact same procedures. And one of the reasons they're able to do that is the use of their market power for truly abusive contract terms. And I'll highlight one, and then I'll stop talking. There's a couple highlighted in HEAL, and if anyone's following healthcare, what's going on in California right now with the Sutter decision, where attorney generals are finally pushing back on exactly the same terms that we're including in the HEAL law. The use of a hospital just saying, because I'm big and rich and powerful, I'm going to demand you have to take this, you have to take this, you have to take that, you have to pay this. But the most egregious piece for me, it shouldn't be a surprise to anyone that the United States has the worst maternal health outcomes of any developed country in the world. Those outcomes are 3 and 4 times worse still if you're a woman of color. We saw those exact same outcomes happening to our members. Mortality, episiotomies, all kinds of complications. And so decided we needed to design a high quality maternal health program. We asked hospitals to participate strictly about quality. We asked them to reveal a level of quality data so we could be sure members would have access to high quality. We launched that program about a year ago, and we're incredibly proud of it. The numbers are incredibly good. Our members pay $0 for pre-postnatal care and a maximum of $40 to deliver a baby. And the quality is extremely high. New York Presbyterian demanded that the program end, said to maintain access to New York Presbyterian, you have to change or end that program simply because it's not generating revenue for us. It's not directing people to our care, but we also won't show you whether or not we meet your quality standards. Because of that all or nothing approach, we had to remove New York Presbyterian from our network. We weren't willing to give up high quality maternity care for our members. And that meant 100,000 New Yorkers lost access to Presbyterian. If we can pass the HEAL law this year, we will stop hospitals from abusing their market power and abusing working New Yorkers. So happy to take more questions, but that was a long speech. It's a really important bill. As sort of Mark said, it's not something that will be in the budget process. It's something we are talking about a lot now, and then we'll try to move when the budget is done.
Mm-hmm.
Yes, and I will
Leslie
share
has-
the link to the HEAL
Yeah.
Act.
Okay, thanks.
Does anybody have any questions up to this point, or should we just keep moving on and ask questions at the end?
Well-
So the next ask is something that even my very conservative assembly person should support, and that's Medicaid eligibility for older adults and people with disabilities. And Mark, do you want to field that one, or Alex? Mark, I heard you give a very good explanation to Peter and I on this.
I'll try to repeat it, but it's not easy. So I'll just start off by saying to do a bit of level setting. Medicaid is the federal healthcare program that provides access to healthcare for low-income people at its core. But over its 55 years or so of existence, it's grown out to be a much more robust and bigger program that covers lots of services for lots of different people. And it's a program that's actually jointly operated between the federal government and the state government. The federal government sort of sets the rules and guidelines and sends us a bunch of money, but the state really operates Medicaid and has a lot of discretion over how it does it within these broad parameters set by the federal government. So one of the historic populations covered under Medicaid has been what's called the aged, blind, and disabled category. And its roots go back to social welfare policy from the New Deal era. But at any rate, it's there. And when the Affordable Care Act came along about 12 years ago, and there was the new Medicaid expansion that happened under that to other categories of people. The ACA Medicaid folks have a much higher eligibility level, and they do not have an asset test to look at your financial resources that you might have in the bank. Whereas the old traditional category of aged, blind, and disabled, they're still playing under the old rules, a much lower eligibility level. And they do have an asset test such that I think if they have something above like $13,000 in assets, which is not very much, you don't have access to Medicaid. So at any rate, this is a way to sort of bring New York's Medicaid program up to the same standard as everybody else has, get rid of the asset test, have a much higher level. So that's what's being proposed here for the Medicaid expansion. It's long overdue. It primarily affects people with older adults and people with disabilities. Some people are surprised, but let me just sort of state this. It is absolutely possible if you're an older person on Medicaid, on Medicare, and you also are low income, you can be on both programs, both Medicare and Medicaid. Mm-hmm. In which case Medicaid wraps around your Medicare, fills in the financial gaps and some of the benefit gaps is sort of how it works. So for aged people, what this new eligibility standard will really make a huge amount of difference for them going forward. So that's
Mark, I'm just wondering, that would fall into the category of people who are in nursing homes or
yes,
care
Medicaid is the big prime payer of long-term care services, both in nursing homes and in the community in our society, because we don't have any kind of official long-term care program. Medicaid by default becomes that program. And so it's a very important program for states and for middle-class families, because that's how they get long-term care for their loved ones.
Right.
Alex, if you want to jump in and make comments, please do.
My comment is always I defer to Mark on almost everything. He's absolutely right on all of these.
Okay, let's keep going.
I see a hand up, Gary.
Yeah, Linda has a question.
Yeah, I just wondered if that was the case only in New York State, these wraparound with Medicaid?
No, it does so nationally, but no two states' Medicaid programs are the same.
Yeah, that's the thing.
That's the thing. So we have a long history in New York on both sides of the political aisle supporting our Medicaid program. We have one of the best Medicaid programs in the country. We should be proud of it. It's a safety net program, and we take full advantage of every single federal option available to states under that law, and it's all to our credit.
Excellent. Yeah, I have it in another state, but it is excellent. That's
it's a lifesaver for millions and millions. Yeah. There are when you add in the sister programs to our state's Medicaid, which are the Essential Plan and the Child Health Plus program.
Oh,
We have well over 8 million New Yorkers are on those 3 programs, well over a third of our state's population.
So that segues into our next ask, which is postpartum Medicaid access and improvements to Child Health Plus.
Right. So we've had one of our Medicaid programs here in New York is called Medicaid for Pregnant Women. It's been around for a very long time too. And it's been built on and improved over the years, like many aspects of Medicaid have been. So the governor is proposing in her budget to increase the, well, before I get into that. The current program right now, if women qualify, pregnant women qualify, they get coverage up to the point of birth and then 2 months post-pregnancy after the birth. The governor is proposing in her budget to increase that time period after birth out to a full year, which is a good thing. However, there's a snag in it, and that is that it won't be extended for certain categories of immigrant women who are not here legally for whatever reason. Now, heretofore, our Medicaid for Pregnant Women program has always covered all low-income women, never asked any questions about immigration. The same thing for our Child Health Plus program. We all a snag, and so we're trying to say to her and the legislature, this is a great idea, but you need to include all low-income women in the program. Where it becomes a budget issue is that we can't use federal Medicaid funding for certain categories of immigrants. And so it would have to come out of state coffers. Now, it's not that much money that they're talking about. I don't remember off the top of my head, but it is money that the state would have to, and always has ponied up for low-income pregnant women postpartum if they don't, qualify according to certain federal laws and regulations. So that's the ask there.
Thank you, Mark. Any other comments? Peter, jump in with any comments if you have any. The next one.
Right.
Oh, go ahead, Gary.
The next one is the global Medicaid cap of either modify or lift it. This is really important to many people.
Actually, I forgot to talk about Child Health Plus, so let me talk about that.
Okay.
So this is a program we've had, gosh, its roots go back almost 30 years now. And it became the model for the federal state child health insurance program that came in about 25 years ago. And like Medicaid, we built on this program and improved it over the years. It's a very robust program for kids right now. And almost any kid can qualify for it, regardless of their family's financial situation, if the child's parents don't have employer coverage, for example, in place. There's up to a certain level of family income, the coverage for the kids are absolutely free. There's a category of folks up to another income level, more into middle income families, that pay $9 per month per kid for that coverage. And then above that level, when you're really into middle and upper income families, then they pay a full regular premium rate for that coverage for the child. What the state's data has shown is that a lot of kids are falling in and out of that middle category because their family's incomes fluctuate over the course of any given year. And because it's only $9 a month, it's really kind of a nominal fee, and it's turning out to be more of a hassle for the state to try to chase those things down and to get kids re-enrolled afterwards and so forth, that the governor's just proposing to kind of get rid of it, not worry about it. Those kids would have premium-free coverage, just like the kids at the lower income from families at the lower income. So that's a good thing, and we want to see that happen. And also, they're building out some of the more specialty benefits kids with special needs in the program that, probably should be there. I'm not an expert in child health, so I can't really speak to that, but that's sort of what's on the table in the budget around the Child Health Plus program.
Thank you, Mark.
And
And
now
this
I'll
is-
move on to the Medicaid Global Cap. So
Yes,
for about a decade now, since Governor Cuomo came into office, the state has imposed an arbitrary annual growth cap on how much Medicaid can go up year by year by year by year. And it was first brought into place with some logic 10 years ago because Medicaid spending had really kind of literally gotten out of control, and particularly the hospital coverage aspects of the program. As Alex was referencing, high hospital bills is an old story. And so, at any rate, these things came in to kind of ratchet that down, and it had some success. It did bring the annual growth trends under control, but it's sort of outlived its usefulness. It's also proven very arbitrary. It's not responded to new things like Medicaid enrollment increased by 1 million people during the pandemic as everybody lost their jobs. And we have the baby boomer generation aging into Medicare and the need for long-term care services and so forth. So it's just become really clear that we need to get rid of this global cap. And so that's sort of what advocates are pushing for. The governor has proposed modifying the growth formula from the one that the Cuomo administration had in place to one that is more, better reflective of the growth of Medicaid and the populations Medicaid serves and the demographic trends and so forth. But advocates in general are saying, let's just get rid of it. Things are under, the Medicaid system has changed a lot in the last decade under the Cuomo administration. So a lot more people in managed care programs now than there used to be. And so there are other mechanisms to control cost growth, and we don't need, we need Medicaid to exist as the entitlement program it is, and that is when enrollment and need and so forth goes up, the funding is there. I mean, we can draw down federal dollars for almost all of it. So why we impose this growth cap at this point is sort of like, we don't need it anymore.
Mark, a number of my parishioners use Medicaid, and they're very limited, especially in a rural area like
Yeah.
to be able to find providers because some doctors just refuse to accept it.
That's
So
always,
if this would affect that, would it not? That would
just, yes, to
give them
some
more
degree.
access to healthcare?
To some degree, it would and it could. I mean, that's also been an old story about Medicaid, is that we have a great program open to a lot of people that covers the full range of services, but there isn't a robust provider network there that's needed to actually provide the services. I mean, the saying we always have is, it's necessary to give people an insurance card of some sort, public or private, but just giving them an insurance card does not mean that people are necessarily going to have access to care. And so the flip side of that coin is, we have to make sure that people have a place to take their Medicaid card once they get it.
Thank you.
Yeah.
so our next one is increase the income limit for the qualified Medicare beneficiary
Yeah,
Medicare savings program.
right.
That's a
So
mouthful.
this is a bit down in the weeds, so hang with me. The federal government has programs that will help people, lower income people who, for whatever reason, don't qualify for Medicaid per se, or they may be somewhat above the Medicaid level, but they're still living paycheck to paycheck, hand to mouth, Social Security check to Social Security check. So they have these things called Medicaid savings programs that help people out with their deductibles for their drugs and their co-pays for doctor's visits and so forth. And it's money that's operated through state Medicaid programs. So it's federal Medicare money flowing through state Medicaid programs. And again, we've done fairly well here in New York on that. But as we now raise, as I spoke about a few minutes ago, the eligibility for Medicaid for older people and people with disabilities, we need to raise the levels for these Medicare savings programs also, so that everything kind of goes up comparable and the whole thing will work right. So that's what's being talked about here. Now, while the governor put in her budget these proposals to raise Medicaid, she didn't include anything in her proposals about these Medicare savings programs that also help low-income people. So we're now turning to the legislature to say, you guys need to do this. Again, it won't be much of a budget fiscal ask because it's all federal money coming down to the state. But we do need to make this change at the same time.
Our last item before we take a whole bunch of questions, which I presume will come, is should have been on the immigration breakout also, and that's coverage for all.
Yeah, and Mark touched on that earlier too.
Is somebody during the immigration break going to talk about coverage for all, or should I do that now?
Yeah, you should, Mark.
Yeah.
Okay. So this is a proposal. It's been around for a number of years. It's really starting to gain traction now, which we're excited about. And some of it is a function of other politically progressive states are starting to expand their public insurance programs to cover more and more categories of immigrants. And we've always kind of had New York here had a friendly competition. We're one of those states amongst each other. So it's kind of like, well, California's doing it, Illinois is starting to do it, let's do something here in New York. So our proposal here is to take our essential plan, which is a public insurance program for low-income people that goes up higher than Medicaid, and open that up to all low-income people, regardless of their immigration status. Just like I was speaking about a little bit ago about pregnant women. This essential plan is an option available to states under the Affordable Care Act to set up these special programs for low-income populations above Medicaid. And we took that option, and it's been madly successful. We have almost 1 million New Yorkers enrolled in it, far beyond what anybody expected. And so it's a program that's already up and running. All we have to do is open it up to these folks. Now, a lot of the immigrants already do qualify in the program, but there are some categories of immigrants who are not deemed lawfully present for a variety of reasons. And so this would open up the program for them. Now, the catch, of course, is because we can't draw down federal dollars for these folks, the state would have to put the money on the table for it. All the other essential plan folks, that is completely federally funded money. So this would be the first time that the state would have to be putting a bit of its own money on the table to cover these folks. And they're estimating, I think, if I remember the numbers off the top of my head, it would cost a little under $350 million for this expansion. So, I mean, that's not chump change, but it's not a lot of money either in the grand scheme of the overall state budget. So, we can find the money. That's not an issue, particularly since the state has a $5.5 billion budget that the governor has identified, and the controller actually says it's much higher than that. That's a conversation for another time. You may have discussed that already in your earlier session, but at any rate, that's what's being talked about here, is to open up the essential plan to all low-income immigrants. It would cover people up to 200% of the poverty level, federal poverty level, which for an individual is about $27,000 a year. Which is, pretty substantial, not a lot, but, and the governor is also proposing in her budget to extend the eligibility level for the essential plan from 200 to 250% of the federal poverty level for the existing categories, which is a good thing. And also if we can add and do the same for immigrants, we'll actually probably be getting close to almost $30,000 a year for income to be able to get this coverage. And the essential plan, no premiums, no deductibles, nominal co-pays at point of service. So it's a really terrific program.
Yeah, and if I can just build on what Mark's saying, it is a really terrific program. It's unconscionable that folks lack coverage because of where they were born. But this is also how these things tie together. We did some very basic analysis that suggests that the state may be getting overcharged by private hospitals by as much as $1.5 billion, right? And that is paying over what the hospitals actually need, not for better care. And one thing that's really important is there's actually no correlation between hospital price and quality of care, none whatsoever that any national study can find. It's just sort of, we're a big private hospital, we have great advertising, we have a lot of market power, so we just charge this. So when you think about the choices, right, and public budgets are all about choices, we can either stand up to incredibly wealthy hospitals and have more than enough money to fund things like coverage for undocumented folks, or we continue to let the state budget just kind of be a, I don't even know the right word, right? But like a huge just kind of boondoggle for hospitals that are already making tons and tons of money while engaging in a lot of, really questionable practices like we talked about earlier. So it's just another place that these things overlay. And I would much rather my tax dollars be spent on covering folks who are undocumented than making millionaire CEOs of private hospital systems even more wealthy. That's just me, but like that's where my values land.
That's just us.
Okay.
So Alex,
So-
how formidable is the resistance from the hospital corporations to the HEAL Act?
And Mark could probably speak to this as well. If you look at state lobbying expenditures, the largest lobbyist in the state is the Greater New York Hospital Association. The second largest lobbyist in the state is the Joint Labor Management Fund of the Greater New York Hospital Association and SEIU 1199. These are incredibly powerful entities. This is why they've been able to get away with this kind of behavior for so long. It's why, even chipping away at things like don't take people's houses because they had to pay for healthcare is difficult, which should feel like, what? Right? These are, Mark, you could probably speak to this as well. These are incredibly powerful entities, and they do not like being told you can't throw your muscle around. So the resistance is pretty significant.
Yeah, I can just say it's long been the case on almost any healthcare issue that comes up in Albany, that the hospitals are absolutely among the most influential lobbies that determines what happens and doesn't happen. So I'll just echo that. Sometimes it's good and sometimes it's not so good. So,
So what questions do we have?
So
How
I'm-
can we take back our power from the hospitals?
I could just add to taking back the power piece, and going back to that medical debt issue. They did a study on just what the average amount of debt people were having and having wages garnished and that. It was only $2,000 was the average amount. And for that people were facing all kinds of repercussions. Interestingly enough, on the medical debt issue, a lot of the hospitals that were really the most egregious are upstate hospitals, believe it or not. Wasn't as much of a downstate issue, although it is an issue there too. But when they shined a light on some of these hospitals that were, taking people to court for these relatively small amounts of money, people who couldn't afford, to have an attorney, they found some of the hospitals actually backed away from, doing things like liens and that, because they didn't want the adverse publicity. So I think shining a light on some of these hospitals that are doing this is one way to do it. But clearly, some of these other bills are in order. I just had one other question regarding that the global Medicaid cap. So if we get rid of the cap, Mark, essentially we just put Medicaid through the regular budget process through the legislature and treat it like anything else, right?
That's right. That's what'll happen. Just like we did before Cuomo came in.
Yeah. And on that issue of the Medicare savings plans, which really are helping people with their Part B premium for the most part, right? Correct? Is that?
Yeah, I think it's primarily Part D. I think it touches on Part D somewhat, but it's more of a Part D program. And again, I'm not a Medicare.
And I believe Senator May has a bill out that's addressing that.
Yeah, this came out last week.
And I don't think it goes as far as a lot of the advocates would like to see it go. But I believe she put in for an increase in the income thresholds in such a way that it would draw down the maximum amount of federal dollars.
That's right.
So I think is that correct?
Yeah, that's what I've been told.
Yeah, so I think that's one that people can get behind for sure.
Yes. Peter, did you have a comment?
So this is kind of a big macro kind of question, but for many of our congregations, we're being asked to really get behind the New York Health Act. We see, for instance, in many of our congregations, people who have their assets drained because of long-term costs for long-term care, which are not covered under any program except Medicaid, where you have to majorly draw your assets down. And yet it's puzzling to folks why we can't get this to move in Albany. And they also note that not everybody in the healthcare advocacy world, including unions, is all in agreement that this is such a great idea. They might point to the fact that California tried to pass this and failed to do so. They tried to do it in Vermont, that also failed. But could people that know much more than I do help folks on this call navigate these political waters a little bit? Give us a little insight, help?
Well, let's see. I think everybody agrees that we should have some kind of a universal healthcare program. Just like Alex was describing, everybody agrees that hospital prices are way too high and something has to be done about it. And there are different ways to go about each of those things. People have different stances on them. And some ways, when you look at the policy literature, are probably better than others. But you're right, you can't just have a good policy. You just have to have politics in place to move the policy forward. Otherwise, it's just a policy on a piece of paper. And so the New York Health Act would dramatically change how healthcare coverage is provided in New York. It would essentially replace the existing system of private insurance, employer-provided insurance, and public insurance programs and safety net programs for the uninsured with one unified program that the state would run and operate and fund through taxes that covers everybody, and would have all the providers in it. So that's a drastic change. It's a vision that many of us support. But the question is, how do you get from where we are now to there, both in terms of stepping toward that policy, but also the politics that underlie it? Because policy and politics are intricately interlinked. You cannot pull them apart. And so what you're asking, Peter, is, is going to be a bit of a challenge for us going forward. Not everybody is in alignment, although we're all in alignment on the goals. We're not necessarily in alignment on what's in the bill or the process going forward or anything like that. All that said, we've got the biggest head of steam and public awareness around that bill than we've ever had. The bill has been kicking around for 30 plus years now. It's been updated as we go. A few years ago, it passed as a one-house bill for 4 years in a row in the assembly by wide margins. And now we have both, large margins in both chambers. We have majority of let me put this correctly. The majority of the majority in each chamber is on the bill as a sponsor. I think that's right. It's like doing double negatives. I'm getting a little confused here, but at any rate, there's good solid support on paper for it. Now, that said, we still have to get it forward in the legislative process. There are numbers of opponents standing in the way. Obviously, those who are making out well in the current system are going to be opposed to it. We have some unions asking questions, some very legitimate, serious questions about, well, what does this mean for our union benefit plans that we have developed and provided to our members over all these years? And those are legitimate questions that need to be answered. And those union leaders are in dialogue with the bill sponsors, Assembly Member, the two health chairs, Assembly Member Gottfried in the Assembly and Senator Rivera in the Senate. And so all that's underway. It's probably going to take some time. So we'll sort of see. I mean, even if the bill were to pass fully in this session and get signed by the governor, then you begin a process of developing the plan for the program, both the financing as well as how the payments are going to work, and building the provider networks and getting the okay from the federal government and being able to fold in all the current federal healthcare funding that comes into New York State into this new program. And that's going to take a good year or two, at least. And then you have to come back to the legislature and they have to sign off on that plan. And then you have to start rolling that plan out. So, we're looking at 2, 3, 4 years before anything really happens under the best of circumstances. In the meantime, it is not an either or. We can do these other short-term things right now to make things better for New Yorkers. We can do things like expand coverage to all low-income immigrants. We can do things like making sure all pregnant women postpartum get coverage for a full year. We can do things like protecting patients from having their wages garnished and liens put on their home. We can do those things right now to protect them while we build toward this New York Health Act, both getting it through the legislature, developing the plan, getting the funding approved, rolling the program out, et cetera. So it's not an either or. It's like we have to walk and chew gum at the same time, and we can do that.
So I'm going to ask you something speculative, which you may not want to answer. In our asks, are there any of these asks that look fairly straightforward and not heavy lifts?
Of the ones I talked about?
Yes.
Let's see. Let me go back and look at this. I think the stuff about expanding coverage for low-income, aged, blinded, disabled, particularly since that's already in the governor's budget, I can't see why that's not going to move forward. It just will. It's likely that we can probably get that coverage for all low-income postpartum women simply because we've done it all along. It's not going to be that much more money. And it really would be a noticeable step backwards, not just that we wouldn't be stepping forward, we'd actually be stepping backwards. So, and I think the legislature is primed to respond to that. I think the legislature is primed on the medical debt protection stuff because they are more and more hearing from their constituents about issues of medical debt and what they can do about it and where they can get help. So I just think overall that's becoming a more prominent issue. And part of the reason that advocates have picked it up and raised that up as an issue in recent years, because it wasn't on our agenda for until recent years, is that in terms of the consumer assistance and ombuds programs that patients turn to for help, it is absolutely risen toward the top of as a concern of people who need help with various aspects of healthcare. So it's just becoming more and more of an issue. So that's sort of what led to that. I think it's likely that these Medicare savings program things will probably happen, particularly as Charlie mentioned, Senator May has her bill in now for it. And the way she's figured it, and I haven't read the bill and I'm not an expert in it, is that this expansion would be entirely federal money. So it's not going to be anything that's going to cost the state anything. So why wouldn't we do it? In that case is sort of the question. As for the Medicaid Global Cap, that's gonna be a tougher nut to crack, simply because the governor has come forward with this sort of more liberalized version from the old Cuomo version. I think some legislators are probably asking themselves, so what exactly is wrong with trying to control Medicaid spending overall? And I would say, advocates would say, yeah, we need to control that spending. It's just the global cap is not, the global growth cap is, there are better ways to do it than a global growth cap. Let me put it that way. And we'd be more than willing to sit down with policymakers, lawmakers, and figure out what that better way is. There's lots of research. Other states have done some very innovative, interesting things. There are things we can do. And that I would say the same thing around the HEAL Act. There's numbers of ways to get at controlling hospital costs. The HEAL Act proposes one. There are other things. We should be looking at all of them and saying which are the good ones that we should be pursuing.
So we've got about 4 minutes left. Thank you, Mark. Alex, would you like to respond to any of the?
Alex had to leave, Gary.
Oh, okay.
Yeah,
Any other questions?
I was just going to say to Peter's point about the New York Health Act and getting that moving, I think people were frustrated last year because, they got a super majority in the legislature, and I don't think the bill got out of committee. So I don't know where you go with that. I know from our perspective, what we've been focusing on is more incremental changes. And there's going to be a paper released by Community Service Society and Citizen Budget Commission, an interesting group of folks working together on putting forth some ideas on how to close the healthcare coverage gap. And I think there's some very interesting things that are going to be coming out of that advocates might be able to get involved with. A number of different ideas ranging from, increasing the amount of money for outreach to help people who are already eligible for essential plan and things like that. So stay tuned, because that's going to be coming out soon.
Yeah, actually, it came out a couple of weeks ago. So
Oh, did it come out?
it's out there, yeah. And there are a number of things, while we, compared to other states, have been wildly successful with our implementation of the Affordable Care Act, building on our success with CHIP and Medicaid and so forth. We now have less than 5% of New Yorkers don't have health insurance of some sort in place. So kudos to us, but we still have 1 million New Yorkers that don't have coverage in place. A bunch of those are immigrants.
About 400,000 of that are undocumented too.
Yeah, right. So we have the largest category is undocumented immigrants. So we're hoping to fix a piece of that by covering low income, all low income immigrants under the Coverage for All proposal. And we're looking to, beef up funding for outreach programs to get to those folks that are already eligible for existing programs, and we just, for whatever reason, they're not enrolled. And so, those are some things kind of in the short term to keep in mind. But maybe I can just close for all of you, given who you are, leaders in faith communities and congregations and denominations and so forth, is it's probably true for other issues we've talked about today. You don't have to be, and you shouldn't necessarily be, the policy experts on this, because there are other people that can do that. You bring the moral imperative in voice. You bring the experiences of your parishioners and everyday New Yorkers from across the political spectrum who need help when it comes to healthcare. So to the extent that you can provide that push and that perspective that makes the issue real for legislators, not just an abstract policy conversation, that's how you can make a contribution.
I appreciate hearing that, Mark, because you're in sync with Peter, whose advice is not to get down into the policy weeds.
Yeah, just the broad strokes. All low-income people need coverage, no matter what their immigration status. That's really, it in a nutshell. All pregnant women postpartum need coverage for up to a year. All those.
We're going away in about 4 seconds now, so.
Okay, sorry.
Thank you for attending,
Mark.
and it's been a great session.
Thank you.